Hello, this brief presentation is for the management of Springfield General Hospital on the topic of redesign. I'm Carlos Martinez, a doctoral student at California Intercontinental University, and this presentation is for Management 616 course, March 10th. The first thing we want to take a look at is the agenda for this short overview. First, we'll discuss the scope of the problem, identification of a credible solution, which you've selected as automation. Congratulations, and the use of CPOE, which we'll define in a moment. We'll talk about the proposed change using a theory in management called Lewin's theory. The role of managers, suggested implementation process. Will conclude with Q&A. I have my content and references. The scope of the problem is nationwide. It affects most medical institutions, if not all of them in one way or another. Here are just a couple of mini references. One from Patient Safety Network in 2019. Medication mistakes is a category commonly referred to as ADEs, or adverse drug events. This results in more than 700,000 emergency department visits and more than 100,000 hospitalizations each year. Other articles refer to the number of actual deaths resulting from these mistakes. Another reference is a 5-year study from the New York Times dated November 24, 2010. It suggests that hospitals have not found a good safety solution. Let's take a look at the problem as it is stated at Springfield General. First, we'll refer to this category as ADEs. The first is prescription errors. This is one of the easiest to correct: poor or illegible handwriting by prescribing physicians. Next is confusion over drugs with similar names. Next is synergistic effects of multiple drugs and patient allergies. In other words, inadequate attention being paid to the data input and resulting in these multiple drugs crossovers causing patient allergies. The result of the ADEs here increase the cost of the institution because they have to correct the errors, and then of course have potential for lawsuits as well. Now, the current use of CPOE has produced adverse results, or an actual increase in ADEs. It has produced incorrect dosage information, which that's resulting, one of the causes, of course, as stated, is the difference between the prescribed dose and what the pharmacy's warehouse has and what they've purchased versus clinical guidelines. Next is discontinuation failure. This seems to be related to having to navigate to multiple screens in order to get the information that the employee hospital, the staff and employees need for prescribing new medication or modifying existing medication. And confusion of patient names and medications. This is coming from color coordination of the screens and not having the ability to identify your patients on every screen, and a couple of other related elements that you've. Well, I want to first congratulate you on your decision for organizational redesign using a modified approach, which is CPOE. Now, the proper use, you can expect these benefits, but we need the participation of all of the staff, employees, the department leaders across the board in every department for the entire organization to make this work successfully. The benefits that you can expect are reduction in errors and reduction in cost overall. I know that will be a welcome benefit. Accurate dosage information pursuant to clinical guidelines versus what the warehouse has and what they have purchased that may be inconsistent with what the actual prescription is. Next, accurate ordering of new medications and modification of existing medications, because the system will correct all of these things. We may need a slight software modification or upgrade, which includes the patient's names and their identification on each screen, even though it is color coordinated, but this is critical as you navigate multiple screens to get the information and do the data input. Now, CPOE, for the benefit of safety and accuracy, and to get the results that you desire, will require the following. All physician prescriptions for medication and treatment must be entered into this system. Now, the computer entries are available to all of the hospital staff in all of the departments. So we'll need training, we'll need mentoring, behavior modification, and coaching in order to achieve this, which we'll talk about in a moment. Third, the system will catch all of the prescription errors, incorrect dosages, duplicate requisitions, patient allergies, adverse impact statements of multiple medications. All of this, the system is designed to do, and if properly operated, you can achieve these results. The system will also display the patient's complete medical history as well as their latest clinical guidelines for treatment. So as we continue, these are the things that you can. Let's take a look at the role of management. The managers, team leaders, department heads, and staff and employees are all critical for successful implementation of the CPOE program. And I'm not sure I defined that acronym, Computerized Physician Order Entry Program or System. Well, first, from the management's perspective, you should expect and be prepared to provide training and coaching on regularly scheduled intervals as a basis to ensure that the required input activities are performed and that the system has the information to produce the accurate results. Special attention should be given to the various departments in the hospital. For example, physical therapy, pharmacy, the burn center, neonatal department, ER, ICU, pediatrics, and others. They all have slightly unique requirements, and the system has been designed with those departments in mind, but we as management need to be on top of, on a regular basis, evaluating and monitoring the protocols for each department. The implementation methodology that we're suggested to use here is by an American-German psychologist who pioneered organizational change in the United States. His name is Kirk Lewin. Now he left us with a 3-step process that is very effective in organizational change. And this is what we suggest to implement here. The first step is referred to as unfreezing, and that's a diagnostic process. It creates employee and staff dissatisfaction with their current status quo. We will need to implement incentives and protocols in place so that your staff right now becomes dissatisfied. They realize what the problems are. They realize that we have a solution, and it's going to involve change, learning, and practice, and evaluations in order to move, which is the next step, from the status quo to a new set of behaviors that conform to the proper use of CPOE. This is a transition or a transitory stage where your staff, your employees, are unfrozen from their status quo. They move to a new set of behaviors, and now, once you, through evaluation and testing, you can determine that the staff is on board with the new behaviors that conform to the changes that produce the desired results that we want. It's called refreezing. And this involves providing additional incentives, maybe new career paths, maybe new sets of skills and learning for your employees so that they maintain their motivation and they see the benefits of the system, the benefits of improved relationships with patients, with team members, and interdepartmental cooperation. The last step in the process of implementation here is a beta test. Now, beta testing simply means that you identify one department or maybe two departments that you would like to implement a test. We will incorporate the CPOE in each department or one department, and we'll test it for a period of time that we predetermine. The benefits of this is that we identify potential issues that may arise for full implementation so that we can tweak that. It's an opportunity for task alignment. Management can be able to evaluate and provide performance evaluations for the staff, establish and examine performance evaluations for all of the employees and staff that's involved in the data input for the system. We want to invite their feedback and ask them to evaluate the system as well. The pilot test or beta test provides additional elements for career advancement. We want to see if we can incorporate any of those elements in there. That's a real incentive for a number of employees to comply with the new guidelines. I think we want to recognize high achievement, so those employees that are really motivated, that really step up, maybe we can recognize them, and it creates training programs for other departments. So as we refine the training and implementation in the pilot or beta test, then we can maybe spread to various other departments or implement corporate-wide. The proper and effective organizational redesign implementation that we've outlined here, it allows for Springfield to become a model health organization in time. And we're pretty confident that you will be satisfied with the results, and we look forward to working with you. I'd like to invite questions and suggestions at this time, and thank you for your attendance.